Welcome to a holistic approach to pelvic floor health. My name is Dan Hellman, and I'm a physical therapist and practicing for over 25 years. I have had the honor of teaching around the world for the likes of Paul Chek and the famous osteopath, Dr. Guy Voyer. I receive inquiries on a daily basis, and one of the most complained about pathologies I receive is about the pelvic floor, from both females and males. The pelvis is extremely complex, especially the female pelvis, because the female pelvis contains more viscera than the male pelvis. Now, there are many causes of pelvic floor pain and dysfunction. First and foremost, there's a saying, structure dictates function. There's a white line called the pubo-vesico-genito-recto-sacral fascia that runs from the front of the pelvis to the back of the pelvis. So if the pelvis is off at all, it will cause a major impact on the viscera of the pelvis. Now, you may need a competent chiropractor, osteopath, or physical therapist to adjust your pelvis, and I may be able to help you with my network of colleagues around the world, so do not hesitate to reach out for a referral. Now, there are two main sources of pelvic pain, and which one, it depends on the triggers that the patient has, as well as whether the symptoms are centered or unilateral. It can also be bilateral. Now, the first source is pudendal neuralgia, and generally this symptom worsens when sitting and when loading the posterior hip muscles. It is not a genital problem, but it actually manifests itself in the genitalia. Now remember, the pudendal nerve is unique because it's both a motor and sensory nerve. The pudendal nerve's path branches off of S2 to S4 of the sacrospinal nerve roots in the sacral plexus. It runs through your pelvis and the gluteal region at the upper end of the hip and thigh bone. It passes through an opening in the pelvic bone called the greater sciatic foramen and runs beneath the piriformis muscle. It is a piriformis syndrome that manifests itself in your genitalia. The nerve then exits the gluteal region through a smaller opening called the lesser sciatic foramen, and it travels alongside the pudendal artery and vein into the pudendal canal, also called the Alcott canal, running through the obturator fascia. There are two pudendal nerves, each innervating the left and right hemispheres of the pelvic floor, the rectum, the perineum, and the vagina or penis. The nerve then divides into smaller nerve branches, one called the inferior rectal nerve, which controls the anal sphincter muscles, including sensation in that area, and the other called the perineal nerve, which controls pelvic floor muscles and the urethral sphincter. It provides sensory information to the perineum and the labia or scrotum of the skin of the penis or clitoris. Now, if you have posterior testicular pain, it is a symptom of pudendal neuralgia. The cause of pudendal neuralgia problems are vast and as follows: accidents or trauma, complications from any pelvic surgery such as prostatectomy, diabetes, difficult labor, those people that are cyclists, or prolonged pressure from sitting. Also, radiation, tumors, and cysts can cause the problem. Another cause is severe weakness of the deep hip rotators, causing a hyperfibrosis and a loss of neural gliding of the fascial passages, thus entrapping the nerves. The deep hip rotators include the following: the piriformis, obturator internus and externus, gemellus superior, gemellus inferior, and the quadratus femoris. Those are known as the deep six. Patients with pudendal neuralgia may have which one side, or bilateral, both side symptoms, usually worse on one side. They get worse when sitting, especially on hard surfaces. Sitting and leaning forward makes it worse as it stretches the piriformis and the obturator internus. And the pain may be localized in the penis or vagina, the perineum or rectum, and the medial buttock, inside buttock, on that side. So there may be numbness of the head of the penis or clitoris. Pain during intercourse is common, especially for women. Now, the second source of neurogenic genital pain is inferior hypogastric entrapment and irritation of that plexus of nerves. These nerves are part of the autonomic nervous system that innervates your organs. This source of pelvic floor pain causes burning or electrical cramp-like feeling in the anus, the perineum, the penis, or vagina. It also can cause menstrual type pain. The pain will be experienced as central in the pelvic floor, causing symptoms of prostatitis, vaginal or perineal or rectal pain that does not spread out to the periphery of the pelvic floor. It can also affect the clitoris or glands of the penis. This type of pelvic floor pain tends to improve when sitting down, assuming there is no problem with the pudendal nerve. Now, this type of pelvic floor pain tends to worsen with stretching of the psoas, the front thigh muscle, or going from a seated position to a standing position, or walking or running uphill. This often is a weakness of the psoas, which results again in that restricted neural gliding through the fascia iliaca, causing pain. Anterior labial or testicular pain is usually caused by ilioinguinal or genitofemoral nerve entrapment. This is due to entrapment of the very same nerves of the psoas, or due to positional compression between the pectineus and the ilioinguinal ligament. This is caused by tight groin muscles and sitting too much while leaning forward, and excessive squat depth. Now, to summarize, you are not alone. Pelvic floor pain and dysfunction is very common, but often not talked about. The vast majority of patients also suffer from stress and anxiety, so reducing tension is a vital component to treating this problem, and during this course, we will cover this topic. Many times patients that are involved in cycling or running sports are more prone, and most patients will have concurrent hip impingement due to weakness of those deep six hip muscles that we talked about previously. Avoid sitting on hard surfaces and avoid sitting and leaning forward or squatting for prolonged periods of time. Again, structure dictates function. Don't forget you may need to have an osteopath, chiropractor, physical therapist manipulate your pelvis to set you on the road to recovery while you are performing this program. I truly hope this program helps you live a joyful, pain-free life.
Okay, everybody, I want to welcome Dr. Heidi Gastler today for what promises to be an ongoing conversation about pelvic floor health. Heidi is the founder of Mountain to Sea Physical Therapy in Manhattan Beach, California, and she holds a doctorate in physical therapy and is a Hellman and wellness trained pelvic floor therapist. She speaks nationally on pelvic floor and sexual health, as well as age-related wellness, and is a medical advisor for the Taboo Group, a sexual wellness company. She believes that a person cannot be fully treated without considering the pelvic floor, and is striving to normalize conversations about this topic. When Heidi founded Mountain to Sea in 2016, she set out to create something that was truly patient-focused, one she describes as a uniquely personal physical therapy experience with extensive one-on-one treatment, and the testimonials from her patients prove that she has done just that. Heidi is also an outstanding athlete and a long life adventurer. She grew up in Minneapolis, where she competed in downhill racing and snowboarding, and danced in a ballet company. Now that she is in Southern California, she takes full advantage of the Pacific and the mountains. When she's not at the beach, you are lucky to find her in the mountains with her dog Doc, hiking, backpacking, or downhill skiing. She believes that life should be lived to its fullest and seeks to arm her patients with what they need to achieve their physical goals. And the tagline for her practice is "Pain sucks, rehab shouldn't have to." And I couldn't agree more. And I'm very much looking forward to learning from her today. So Heidi, did I leave anything out?
I think you got it all.
So you want to just jump right into this pelvic floor discussion?
I do. We have a lot to cover in a short period of time.
I know. And I know you're busy, and I appreciate you being here talking with us all, because I'm going to kick this off. I'm known as the back pain guy, but because I did a little article on the obturator internist several years ago on a blog, I would say I get probably 5 to 6 inquiries a month about pelvic floor problems from males and females. So let me start by asking you this. Do you think the pelvic floor issues are increasing among people? And if so, why? And they seem to be prevalent. Has it always been this way, or is it just because we now have the internet?
So it's a little bit of a combination of both. So number one, the pelvic floor problems have been around for forever. I mean, everyone, regardless of gender, has a pelvic floor, and we all get pelvic floor dysfunctions. That being said, it's been a real stigmatized topic for a really long time. And fortunately, in the last few years, likes of people like yourself who've been talking about it, Gwyneth Paltrow, other people who are on blogs and have big internet presences that are starting to talk about sexual health and dysfunction, it's really kind of helped to destigmatize this issue and kind of bring it more to the forefront, which I think makes it feel as though there's more problems when really we're just talking about it more. The other thing is that I do see, and there's absolutely no evidence for this, there's no that, but clinically, I'm starting to see more of these problems present, I think, more as an overuse injury. And in areas like you're in Florida and where I'm at in California and other more like the southern states like Texas, a lot of sports are no longer a one season sport, it's an all year sport. Like soccer or volleyball here, for example, instead of it being a seasonal sport, we're seeing kids specialize in this younger and younger. And we're seeing a lot of overuse injuries happen earlier in life. We're seeing that with things like ACLs and ankle injuries. But we're also seeing with pelvic floor dysfunction, or I'm seeing a lot of younger people coming in with pelvic floor dysfunction as a result of overuse. And I believe it's because we're literally not allowing these athletes to get enough recovery time. And we're not training them to basically have that recovery, training them with things like breath work. And instead, these muscles are getting so tight and tonic that's actually leading to more dysfunction earlier in life.
Yeah, that makes complete sense. And I'm sure we'll go down this rabbit hole about, hypertonic or hypotonic, because some cases, you see people that actually have a very weak pelvic floor, but now we're seeing people that actually have a very tight pelvic floor, and we need to have a happy medium. What are the issues you see in men and women as they age? And what can men and women expect in their 40s, 50s, 60s, and beyond?
So 40s, 50s. We're all getting older here. So, when we start getting older, regardless of gender, we have a number of things that happen. One of them is hormonal changes. Another is the loss of collagen in our tissues. And then the third is a lot of atrophy. As people get older, not everyone, but a lot of people kind of start having underuse or disuse. And this affects muscles in our face. And like a lot of people, we're conscious of like our sagging face and skin. A lot of people are, kind of going like, oh, my tricep's not as firm as it used to be, right? Yeah, you kind of get the wobbly tricep. But what people don't realize is that the pelvic floor muscles are skeletal muscle, just like our bicep and our tricep. So if we're getting disuse here and we're getting sagginess in our skin here, that also affects our pelvic floor tissues. And so that is affected by hormones, loss of collagen, loss of muscle strength. So all of the things we do for the rest of our body, we really need to be doing for our pelvic floor as well. Because those muscles have a whole myriad of functions that people don't realize that they have. Our pelvic floor supports our continence, so that's urine, gas, feces. It's also part of our sexual health and wellness. So a lot of times for men, we see things like erectile dysfunction. For women, we experience something called vaginal atrophy, or you can have women saying that they are unable to climax. In the sexual realm, we may have incontinence issues as we age, but also things that people don't really attribute to the pelvic floor and don't realize are part of the issue, such as a loss of core muscle strength and stability, maybe some loss of balance, which can contribute to like falls risk.
Sure.
That we see when people are aging. Also, when we have kind of that loss of breath, we feel more winded early. Our pelvic floor is actually part of our breathing function. And so that's something that we can see as people are aging, that actually has impacted our core muscle strength. So it can kind of be these myriad of functions that all have to do with the pelvic floor due to this loss of things. So having healthy weight as we get older, actually using these muscles and making sure, again, like you said earlier, we have that happy medium as we get older, making sure that we're working on people's breath work, making sure that we're kind of just in general keeping and maintaining our health. Like we're not trying to get diabetic, overweight, not smoking too much. All of those things can contribute to our pelvic floor health and maintaining that as we age.
I think that's great. I mean, it is a muscle, and like the diaphragm and all these muscles that we don't see when we look in the mirror, they tend to get neglected. And as you're the expert at, we know we have specific exercises that can help people with their pelvic floor as we get older. I mean, yes, of course, we're going to have the hormonal changes, but there's a lot of things that we can do to offset those hormonal changes with the proper exercises. Don't you agree?
Absolutely. And also things like making people sure people are managing stress, sleep, all of those other things too that we know affect our hormones also.
Yeah. So next question. We know that the pelvic floor involves much more than the pelvic muscles. And by the way, a lot of these questions I get from people that follow my blog and stuff.
Mhm.
We know it's a complex area of the body where muscles, organs, nerves, glands, and blood vessels all live and interact in close proximity to each other. What kinds of challenges does this present to the individual and the therapist or the physician? And we should, a little caveat here. Yeah, again, I'm finding pelvic floor stuff in men, a lot in men as well. But the woman's pelvis is a little bit more complicated than the male pelvis, and we have a lot more structures there, and there's a lot more that can go wrong. So I just wondered if you could talk a little bit about all that interaction between all of the different viscera that's there.
Sure. So some of the things, like I think one of the things that's like a really difficult issue when we're dealing with this, just first and foremost, is just a flat out lack of education. And this starts with the providers. So with medical providers, a lot of medical providers are not educated in this area.
Right.
It's totally outside of their wheelhouse. So people just don't even think to look here. And I get that a lot, where I get people who are referred in to me for other problems, and it's really a pelvic floor issue, but it's an orthopedic referral. And so it becomes a lack of education, I think, number one, both on the provider side, and then on the patient side. Like we said, this is kind of a hidden area and a very stigmatized area. And so getting someone to have a buy-in to letting us treat this area becomes very difficult. Now, for women, unfortunately or fortunately, we, I think, A, talk about this more amongst ourselves for the most part, and B, a lot of women were more used to having like gynecological exams.
Right.
So I find that it's easier to address and treat this with women. But when I bring this up with men, this is, again, it's a kind of a more sensitive topic and issue, and something that, again, is a bit more stigmatized, I think, still in men, and has not completely been changed as much as you would. So I think there's kind of a lack of education and a buy-in. Those two things make this a difficult thing to treat, because you're telling someone, hey, listen, I might need to go into your vagina to treat this, or I might need to go into your rectum to treat this. So it's a very invasive thing. And also you've got things like, you have a lot of bad actors where people are kind of going like, do you really need to treat this? Like, I've heard about this, it sounds sketchy, so getting that is difficult. Then when we're dealing the structure itself, we've got the musculature, we've got connective tissue, including a lot of ligaments around the sacrum and pelvis. We have the tendons, we have the viscera, the kind of all the fascial tissue, and then we have the organs and cells, and they all interplay. And so you have so many different things, and oftentimes you need not only one provider, but you actually need a care team around a patient in order to fully address it. And again, this is a lot of work on the patient side, and you have to get a lot of buy-in going, okay, so I need you to see me, but I might also need you to see a urologist or a urogynecologist or a proctologist. I might also need you to see like a sexual wellness counselor or some sort of a therapist if we're dealing with like a chronic pain issue. So you're kind of having to get this buy-in on the patient and also create a care team around somebody. And this is something that's on me to do as a provider. If someone comes in and doesn't have that in place, is going, all right, I'm going to create a care team of people I trust around you. So we have that trusted care team, but it requires a lot of work. And that makes things difficult because it isn't just a quick fix, which everyone wants a quick fix. So a lot of times people will kind of go to like one doctor and offered a pill, birth control being a real common one, or Viagra being another common one. And they go, oh, my problem's solved. It's just a Band-Aid, right?
Right.
But these things make it difficult to treat this because there's so many structures and also so much buy-in required, and a lot of education, both on the part of the provider and the patient, to deal with this.
Yeah, just a couple follow-up comments. I mean, I think we just got to keep it real. And like you said, I mean, this is life. This is everyday occurrences. You're not alone. I mean, I grew up in a small town Catholic family. You didn't talk about your feelings, your emotions. You didn't sure as hell didn't talk about your pelvic floor, right? So I think I think you're right. No, I think it's really important that people know that they're not alone. As a matter of fact, I think it's extremely prevalent, and the ones that we don't even know about, it's even bigger than we think that it is. And, talking about those structures, you and I talked about this before, but the great wizard, Dr. Guy Voyer, breaks the body down into 4 diaphragms. We have the cranial diaphragm, the cervical thoracic diaphragm, the actual thoracic diaphragm, and then the pelvic floor diaphragm. And he will always say, if you have those 4 diaphragms in order, you're healthy. And, that pelvic floor diaphragm being so important because it's the bottom of the structure. It takes a lot of, if I jump up and down right now, luckily my organs don't fall through my body. And that's because of the pelvic diaphragm. And so there's just so many structures down there, and it's so important to keep them healthy.
Mm-hmm. And it's so
Uh,
easy for those things to get out of whack. I mean, when you're talking about like the diaphragms up here, the number of patients that I have come in that have cervical dysfunction and TMJ issues, but then we start working, and then all of a sudden it comes out somewhere in, in the middle of their sessions that they also have incontinence issues.
Yeah.
And then you start tying these things together. It's, the body is very complex, and to treat somebody holistically, we really have to consider all of these aspects and how they interplay.
Yeah.
It's not just even the viscera, it's like head to toe.
Let's move on to pregnancy and the pelvic floor, because I just had somebody in here 2 weeks ago, and she even had a C-section, but so she didn't even give a natural birth. So her pelvic floor is somewhat spared. But I find this all the time where she's had a C-section. I'm treating her husband. Her husband tells me about his wife that just gave birth. And I said, well, he says, is there anything you can do? And I'm like, oh my God, there's a lot of things we can do. I mean, has she been taught how to, because the deepest core muscle of the body has been cut in the transverse fascia, or the transverse abdominis? Has she been shown how to do scar work? Has she been, no, the doctor doesn't want her to do anything. And to me, that just, I want to bang my head against the wall. So let's talk a little bit about pregnancy and childbirth. And I'm sure that presents some significant challenges for women. And how do you advise and treat women during and after pregnancy?
Yeah, so during pregnancy, the first thing is that when you have a pregnant person, you're trying to maintain what fitness they have. You're trying to manage pain and discomfort, because both of those things are going to affect the overall pregnancy. It's going to affect the baby's health and well-being, because we know that baby feels what mom's feeling. Okay, and there's a factor that interplay. And also it's going to affect the birth. Now, that being said, a lot of women come in and go, I need to learn how to do a Kegel in order to birth. And that is not true. Okay.
Right.
I want to kind of dispel that myth, because the number of calls I get about that in a given month is really high. Okay. So when someone's birthing, okay, when you're trying to give birth, Kegels are not pushing your baby out. All right. So you don't need to learn how to do a stronger Kegel. Your uterine contraction is a smooth muscle contraction. We have no control over that. So right. That is something that's birthing you, not Kegel. So
well, I would think doing a Kegel would be the reverse.
Exactly.
Like it'd be counterintuitive to me.
Yeah, but people don't understand that the Kegel is lifting everything up and in, not allowing baby to come down and out. So it's just again, a lack of education and understanding about how these muscles function. So the education piece becomes, okay, teaching a woman how to maintain posture during pregnancy, maintain her fitness. So we don't add fitness. So like if someone is doing CrossFit or doing Pilates or doing yoga, great. Continue to do anything and modify for comfort and for safety as we go. We don't create an athlete during pregnancy, but we maintain what they can do. If someone isn't an athlete, just be as active as you can, go for walks, do things, because maintaining healthy weight and fitness is going to just make your pregnancy easier and also the postpartum area easier.
Right.
But then teaching people breath work, how to actually relax the pelvic floor, that's going to actually help somebody with a natural childbirth if that's what they're doing. And so then in the postpartum, if we have scars, and that can be from an episiotomy, if someone's having to get cut to have baby come out, we have tearing around the vaginal area or a C-section, we're dealing with scar management, so doing scar tissue work, okay, no matter where that is. And I tell everyone, whether the baby comes out but naturally through the vagina or you have a C-section, we're having to rehab something. We're rehabbing the abdomen, we're rehabbing the vagina, something's getting fixed afterwards. There's always some sort of a trauma to get baby out. So we do, scar tissue work. We're working on reintegrating the core, reintegrating the pelvic floor musculature, making sure someone can get that neuromuscular control again to activate and engage the pelvic floor, reintegrate it into their system, into their breath, so then they can use that as a whole systemically, and then get them back to like whatever it is that they love to do. So we're kind of doing these like different steps.
Right.
But
it's just amazing to me how just the disconnect with what scars do to the human body and how they literally can shut down muscle function. and
Absolutely.
not having that knowledge, as you know, again, for this woman that I saw, just giving her that knowledge of being able to start to self-manipulate that scar to keep everything from adhering down, I think is so important. And it is such a simple thing that can be done. So it's really
Absolutely.
wonderful, all the things that you just told us about. Let's move on to men for a second, because again, I get a lot of men. Like women, men experience incontinence. But while women have to deal with menstruation and pregnancy, men have unique problem affecting potency and ability to ejaculate. And how do you approach these problems with men? And may I ask,
Yeah.
what percentage of your clientele would you say is men?
So most of my male patients who come in don't know that they're a pelvic floor patient until they arrive. Okay.
Yeah.
To start there. So most of my male patients, because again, very few men are kind of coming in being like, I want to have help with my erectile dysfunction. I mean, it's just not something that a lot of men want to talk about or want to deal with. But a lot of times I get male patients who come in who are a hip or a knee or a back or something else, and they end up being a pelvic floor patient, and this becomes part of their care. Okay. And again, you kind of start building this trust relationship, things come out in sessions, and then you start to deal with them as part of the, holistic treatment of somebody as we go along. So I'd say percentage wise of my pelvic floor patients, it's probably like 95% women and 5% men, and it's just because there just isn't that same, drive for men to come in. And men, I would really, kind of say are very underserved in this, this part of this community. And again, we need more education getting out there and people talking about going, hey, listen, this is normal. And this is something you can deal with, and there's help available. So like normalizing this conversation and destigmatizing, I think it is really helpful. So for men, if we're having a problem with the pelvic floor, oftentimes there's kind of a multifactorial component. One of them is a lot of times a reduction in testosterone, which can be a lot of lifestyle factors. So this again may not be just me. So I can help with people with sleep management, trying to change their exercise program, have them work with like a dietitian if they need to, managing other comorbidities. So a lot of times when I have men who are having issues, there's some other comorbidity. It might be diabetes, smoking, too much drinking, whatever. So we have to kind of manage those things. And that might, again, tie into like a multifactorial care team type of a system. But then for us, it's like, then like in clinic, we're doing an exam to see what isn't working well. Okay, so that may be the muscles are too tight and tonic, so that hypertonicity, or it could be that there is a lack of tone. In my clinic here, I see more hypertonicity where men are so tight and tense, they're holding everything, and that's actually compressing on blood vessels that are in that vascular area, potentially compressing on that pudendal nerve, not allowing for as much nerve conduction, not allowing for as much blood flow, so we're not having as great erectile function and ejaculation ability as that they could. So if we can get them to breathe better, have better posture, so again, our diaphragms are working in coordination with each other, that we're not having so much stress on that pelvic floor, that can be really helpful. Working with men on how to mobilize muscles like the bulbospongiosis, which basically is between like the anus and the scrotum, the ischiocavernosus, which is kind of more like a V-shaped muscle kind of underneath, like in the kind of pelvic saddle, and the adductors, so our inner thigh muscles, like those three in particular can be really, really tight and tense. And by helping to release those and teach men how to release that can be very, very helpful. If I have men who are unable to produce a Kegel, teaching them male Kegels can be helpful. And there is a home biofeedback device I actually really like for men that's called the K-Goal, and it's an external device. Okay, so you don't have to put this internally. It's an external device to help men with visual aid because it connects with Bluetooth to your phone, like to an app. You can then use that to help to really see, am I doing a Kegel properly? Am I actually doing this right? And that's something they can use as a home tool as part of a home exercise program. And I really like that because a lot of times verbal cueing alone isn't doing it for people. They need that visual feedback as well.
Yeah, a lot of times it's really interesting trying to tell to your male client and tell them what a Kegel is.
Yeah.
They look at you like you're an alien.
Well, they're kind of going like, well, isn't that something girls do? And it's like, yes, girls do it too, but you also have a pelvic floor.
Yes.
And that's one of the things. people don't realize that this is a genderless problem. Everyone
Exactly.
has it. Doesn't matter. It's all affected.
Yeah, exactly. So, and this is another question from a dear friend of mine.
Mhm.
We hear a lot about something called chronic pelvic pain syndrome, which apparently affects a significant percentage of men. And
Mhm.
its causes are a mystery. At least it is to the medical field, to the doctor. And pharmaceutical treatments have changed. We've gone from antibiotics to alpha blockers, and we still don't know why. How do you approach chronic pelvic pain syndrome?
Okay, so I see this both in men and women. And with the first things first, if someone has not had kind of diagnostics, I will send them out for that because we want to make sure that there isn't an underlying kidney infection, UTI, tumor,
Tumor,
things
yeah.
like that. Spermatocele, like those things can happen. For women, endometriosis, fibroids, we want to kind of make sure that we know if those things exist, because if they do, that's going to kind of change our potential treatment plan or make
Yeah,
it so that maybe if there's an infection, especially, that we are not the person for that person to be seeing.
right.
So the first thing is I make sure that we've kind of cleared those things. After that, it's a lot of the things we've already talked about: breath work, relaxation of the musculature, making sure that people can work on relaxation, down regulating of the central nervous system, and helping people, again, doing that through breath work, potentially meditation, having people do that to help down regulate, because that can help with reducing our pain.
Mm.
From a tissue work perspective, doing visceral tissue work, doing manual tissue work. Again, for men, it might be to those same muscle groups I mentioned. If someone's willing to let me do it, doing bulbospongiosis, ischial thigh adductors, also really getting into the deep abdomen and doing diaphragmatic releases can be helpful if someone is, again, willing to let me do that. I do have a few patients that we will do like interrectal treatment, but most of those men, I mean, that's a tough thing to convince someone, again, get that buy-in for, but it is something that we do if someone is game for that. And again, that just helps access more of the deeper pelvic floor musculature to help with relaxation. With women, we would do that intervaginally most of the time. And again, helping with that relaxation. And there are tools that people can use for at home to then do some of those treatments and replicate that at home, as
Yeah.
well. And then lastly, like sometimes we will dispense or prescribe like a durable medical equipment device. Then that might be something like an electrical stimulation unit, like TENS unit, or something for somebody to be using at home. It's a non-medication device to help pain management.
I want to address this now, so in
Mhm.
case I forget, because I think it's really
Yeah.
important. I want to come back to the stress point. So if I forget, please remind me. Uh, Internal work.
Mhm.
Number one, do you think that it's absolutely necessary? And number two, since you're in California and a lot of my patients are not, and the clients are not, is this something that you can teach them to do, let's say on a one-on-one FaceTime or Zoom session or something like that?
Yeah. So internal work is, I think, a tool, but not a rule. So it can be helpful, and sometimes it's needed to get to deep musculature for certain, like, depending on the diagnosis. But for a lot of reasons, we may choose not to do internal work, and that could have to do with prior medical trauma or prior, like, sexual history trauma. It might have to do with age. When I said that we have a lot of younger athletes having pelvic floor issues, if I have a 15-year-old kid coming in here, I'm not doing internal work.
Right.
It's like I'm not trying to add to their trauma. So for trauma reasons, age-related reasons, or other like patient personal preferences, we have to really respect a patient's wishes. Like if someone is like, I don't want to do that, there are all sorts of other things we can be doing externally and with kind of down regulation, breath work, and whatnot that can help to affect the pelvic floor and influence positive change without ever going internally. And then in terms of the virtuals work for a lot of patients. And for a
Mm.
lot of people, I can have them get tools to be using at home. And even like camera off, we can be on a Zoom like this and just have them turn their camera off. And I can be talking them through how to use those tools on themselves, or they can be at home in the comfort of their home and doing that. And during COVID, we did that very successfully for like a good year with a lot of
I was gonna say it probably opened the door for a lot of people accepting internal work because they're at home in the comfort and safety of their own home. They can do it themselves. They can turn the camera off. And I'm sure it's probably was a lot less threatening to them than going and seeing somebody in a clinic.
And like, honestly, there's a lot of patients who I see in clinic who don't want to do internal work with me, but are open to the idea of learning how to do it and then doing it to themselves at home. So I may have them get tools in clinic. I kind of talk them through how to do it, and same thing, then they go home and do it. So it's whether they're in person or virtual, it's basically the same experience, but it definitely has opened that door up a lot. And there's a lot of ways that people can self-treat and a lot of great tools to self-treat that we can use.
So with that said, for all the people that are watching this and that are suffering from some sort of pelvic floor dysfunction, would you be open to working with them virtually?
Absolutely. I'm welcome to reach
Wonderful.
out. Just send them my contact info.
I absolutely will do that. That's great. And so I want to also revisit this stress bucket sort of topic, because one of my mentors was Paul Chek, and Guy Boyer would say the same thing. They just said everything differently. You know, the human body is like a big funnel, and we have all these stressors coming in, 6 different types of stressors: electromagnetic stress, physical stress, psychic stress, chemical stress, thermal stress. And these stresses summate in the human body. And I remember Paul would always say that the cells don't know the difference between the death of a loved one or doing too much CrossFit, because your body releases glucocorticoids. You know, stress is stress at the cellular level. And that always stuck with me. And then Guy Boyer comes along and says, yes, it's like the funnel, your body's like that funnel, and we all have a weak link. Like for me, it might be my pericardium. For you, it might be your stomach. For Susie, it might be her pelvic floor. For John, it might be his pelvic floor. And when we get the stressors of daily life coming flooding in, it's going to be our weak link that speaks to us. And I think that's really important for people to understand, because like you're talking about reducing stress and kind of like those fundamental principles, I think are really important when you're dealing with the pelvic floor issue. Do you have any comments on that?
No, I cannot agree more on that, because so many people that I see, you know, some sort of stress that they're having is influencing the pelvic floor, whether that's stress in their relationship, whether that's stress on their body. And we see things like as simple as this, you know, it's like somebody is stressed out and they're holding their breath because they're stressed, and then they come in and they're having stress incontinence and they're leaking. But what they don't realize is that they simply just were breathing better, that symptom would go away. And I've had several of those patients in the last year where they came in and literally during their, like our talking part of our first examination, I was like, so when you have to go to the bathroom and you're running to the bathroom, do you hold your breath? And they're like, yeah. And I was like, well, let's change that. And they call me and they're like, my symptoms are gone. You know, and it's just like it's just a physical stress, right? And I wish that every patient was that simple, right? Because it'd be so great. But like oftentimes we see that there is that physical stressor that like creates this big problem. And again, we have, as we've already, you know, said, like all of these things interconnect, right? So if you can kind of remove one stress, you never know what other thing is going to be tied to that in the body, that this symptom improves, but also this symptom changes, you know, or vice versa. So that's something that I really am mindful of in the clinic, and I think is incredibly important for patients to be mindful of. If they can work on stress management, a lot of their symptoms may improve, whether it's pain, incontinence, what have you.
Right. And so this next question will kind of follow down on that same similar topic, but given the nature of pelvic floor and its relationship to intimacy, emotions must play a role in pelvic floor health. So how do you deal with that as a pelvic floor therapist when, you know, the human being is a physical, emotional, mental, and spiritual being? And, you know, I've always liked the terms, there's issues in the tissues. You know, we store a lot of stress in the tissues, and we all have life experiences, and some of them are not, you know, some of them may have not been so pleasant. So when you come across that, how do you deal with issues like that?
So I really encourage patients to be gentle with themselves and kind of come as they are and start where they are. So we have a lot of patients, and like one of the big like kind of groups I have in clinic are women who are like 70 plus that have not had sexual intimacy for many, many years for a variety of reasons. Death of a husband or a partner, divorce, etc. And a lot of people just don't even know where to start. And so I just encourage people to be really gentle with themselves, take it slow, and maybe even start with other erogenous zones that are not their genitalia. Because a lot of times kind of going right for the genitals with sexual health feels very, it induces more stress than it's worth.
Like invasive,
It's like,
yeah.
yeah, it feels invasive. It feels threatening for people. There's like this inherent feeling of threat. So, it's just like, even like starting with like self body massage, maybe they get some sort of like sex toy that is not like an internal toy. It's maybe like has an external vibratory function that they can start using externally, really start looking at like, maybe figuring out like what gets them in a relaxed state, whether that's candles or music or a bathtub, and kind of exploring these kind of other external factors and finding ways to kind of reconnect with their body and themselves and the feeling of self-touch and kind of that intimacy with themselves, and finding what works for them and what doesn't, and what they like and find pleasurable, and then being able to convey that potentially to a partner if a partner comes into play, and kind of taking that from themselves into a partner. Because I find that then if they can communicate that better because they know what works for them, I think that really helps to kind of move them through the steps.
Sure.
Right.
And what about if you come across, and I know you have, if you come across somebody that's maybe had some abuse, some sexual abuse in their lifetime that could be perpetuating and actually causing the problem?
Yeah, so a lot of times I work with sex therapists or I work with people's counselors, and we kind of co-treat. So again, exactly what I just said about that gentleness and kind of working with themselves first. But a lot of times we have to get some sort of a therapist involved in order to work through the emotional, mental barriers as well as the physical barriers. And that is so common. And it's nothing to be ashamed of. It's like a lot of times people need multiple stages of help and multiple, again, practitioners to come in to help them to work through that problem.
Okay. Can you explain what a hydrocele or spermatocele is and what causes them in men?
Sure. So we don't treat a lot of those in clinic, okay, but because that's usually more like a urologist problem. But a hydrocele is when you get fluid around the scrotum. So it's basically like a swelling of the scrotum. It happens a lot in children where it can be kind of abdominal fluid draining into the scrotal sac, and it's called the communicating hydrocele, which kind of, it hasn't closed off and it's kind of draining down. You can have a non-communicating hydrocele that happens for other reasons. In adults, we usually see it more because of trauma. And the biggest thing to do is to protect yourself. So that's why athletic cups come into play, and kind of making sure that you're protected so that you don't have trauma to that area. A spermatocele is when you get a cyst in the scrotum, and it's actually in the epididymis, which is where the sperm kind of comes and communicates. It's in that that area that the spermatocele forms.
Okay.
Most of the time, people kind of feel like a heaviness or soreness in the scrotum. Their scrotum might be kind of swelling, but instead of being like the swelling around, it's inside. And generally, that's something that is a benign issue. But if it gets big enough and uncomfortable enough, then like a surgeon would go in and take it out. But generally, those aren't things that we really deal with in clinic.
On a hydrocele, is that, let's say I was playing baseball when I was in teenage years and I took a hard shot to my genital area. Is that something that can develop later on in life, or does it typically develop soon after trauma? Do you know?
I think it's pretty acute. I haven't really seen a lot that are super chronic. The main thing that I think that you'd have a chronic one is if you have some sort of issue with like your lymph nodes, like in the groin region. Like say we have like some sort of a cancer or something, and then fluid is backing up into that area. But it's probably be more like a lymphatic issue more so than anything else.
Okay. And then, so since we're on activities, let's talk about activities that are not good for the pelvic floor, like cycling and things like that. Peloton, yeah. You have any comments on certain activities that you would tell people with pelvic floor issues to stay away from?
So with a lot of people, especially men, one of the kind of classic things that we see is issues with like long distance road cyclers, triathletes that just spend way too much time in the saddle. And Yeah. And so what happens is that the testes are trying to kind of elevate up. And so you can actually get a strain of a muscle that's called the cremaster that's kind of trying to elevate those testes up. And so again, if that's happening, one is to remove the irritant, and to take kind of more rest time. So instead of riding daily, maybe you're kind of giving yourself more rest cycles in that ride. Also working again on the tissue. You could be working on yourself or have a therapist working on the areas of the muscles we already talked about for men, that bulbar spongiosis, ischocavernosis, and kind of getting up under that to loosen it, adductors, helping that to relax. Deep breath work to can help that pelvic floor relax, because those things can all then just influence everything we've already talked about. For women, we see a lot of more issues with kind of like jumping, running stuff. And so a lot of things with like volleyball, like out here, we have a lot of sand volleyball, runners tend to get kind of that. And a lot of times with the runners, someone has told that runner to do a Kegel the whole time they run. And that's something that we have to kind of break that pattern, because we don't hold a Kegel the whole time we run. So doing things like changing someone's posture, getting them in a little bit more of a forward lean when they're running, or say if they're a CrossFitter and they're doing double unders, getting them into a little bit more of a forward lean position, teaching someone to let that pelvic floor actually relax, which feels really scary because it feels like you're going to leak, is something that we can kind of teach people how to do that. Jumping athletes like the volleyball players. And it's something that kind of you're having to instill confidence and kind of re-educate that neuromuscular re-education for people. And the rest to work cycles. I see so many people again that are overworking the tissues, and these tissues are just kind of getting abused too much. And so it's just like a muscle strain of any other area of the body that they need more work to rest. And like the last thing I see a lot is issues with people who are doing really heavy lifters, like power lifters, or going really deep into a squat, or really overloading that pelvic floor. And then again, it's kind of teaching them how to use posture, breath work, proper inter-abdominal bracing. And so working on those things, somebody, and again, integrating work to rest cycles.
Yeah, you just joggled a story that has stuck with me forever. When I was teaching for the Czech Institute, and I was teaching to a very large audience, and I had just finished, and the next presenter came in, and the first words out of her mouth were, "All right, everybody, suck your stomach in, tighten your pelvic floors. You never know who's watching." And I thought to myself, wow, you just gave the entire class an inverted breathing pattern and a hypertonic pelvic floor with that statement. So I think a lot of times we are our own worst enemy. Like, we forget what it's like to be a human being, and we're walking around like a robot, and we're not robots. So, always keeping your abs contracted, we talk about, one of my interviews that I did for this program is with Alessandro Romagnoli. He's a breathing specialist, because that's first and foremost. It's what separates you from a dead person. If you're not breathing right, you're going to have a myriad of issues that are happening in the body. So I think a lot of our pelvic floor dysfunctions are kind of self-inflicted sometimes.
I don't disagree. I mean, I grew up with a ballet instructor who is like, suck on your stomach, tighten your butt, squeeze your pelvic floor. And if your booty wasn't tight and your abs weren't tight, she'd come and poke you in the butt cheeks with a stick. I mean, this is in the 80s, mind you. It would never fly today, but like, it's like you learned. And I was like, trust me, I'm sure my pelvic floor was incredibly tonic my entire time growing up. And, now I live in the land of like actors and models, right? And every woman is walking and pulling in their abs and pelvic floor, and you kind of walk around in that position and realize that like, then you're breathing up here. We're not getting any relaxation down here. So convincing a woman to actually like unclench her abs, unclench her butt, and like let things go is actually a very challenging task just for general life when no one's looking, let alone when people are looking.
I look at everybody's breathing pattern when they come through my door, and it's astounding how many people have inverted or are upper chest breathers. I would say it's 90% of my population.
Yeah.
So
everyone's necks hurt.
Yeah. And they wonder why their neck hurts. One of my favorite topics, do you think the pudendal nerve is often a problem, or do you think it's a scapegoat?
So it obviously isn't. I mean, it's obviously a pudendal nerve issue because it's just kind of like the sciatic nerve and the fact that it integrates and innervates so many areas. That being said, kind of like sciatica, when you have a pudendal nerve issue, you have to figure out what's irritating the pudendal nerve, because something's irritating it. Is it coming from something happening at the sacral level? Is it a muscular entrapment? Is it a positional thing? So I don't necessarily think it's a scapegoat, but I think a lot of times people get fixated on like, I've got this nerve pain, and they're not backtracking it to like the pain source and fixing the source of the issue. And I think that we kind of need to focus on that more. And thankfully, I don't see a lot of people getting like pudendal nerve blocks or anything out here. I don't see a ton of that. Very occasionally I'll get something like that, but most of the time, we're having to just backtrack the source of the pain and figure out why the pudendal nerve is irritated and inflamed.
Okay. I had another question on the Kegel, but I think we pretty much beat that one. I mean, we know Kegels are important, but it's not the end all be all.
No.
Let's see. And then we talked about the internal work. Okay, so how about this one? Because you and I are both kind of similar in what we do. We're both physical therapists. You're specialists in the pelvic floor. If we look, we both practice holistic and a personal form of physical therapy, and I don't recommend medication except for the last resort. Usually, like if I tell people, they're going to need some sort of medicine, I refer them to a doctor. I mean, when it's above my scope, obviously. But what is the role nowadays in medication for pelvic floor dysfunction? I mean, is it still kind of like nerve-based medication, neurotins and things like that? What are you seeing prescribed?
So the thing that I really don't like to see is when someone is like a woman is blanket thrown birth control. And that's a real common one, is that they're just throwing birth control and it's like, this is going to fix the issues. And oftentimes it just masks them. And for men, they're just blanket thrown testosterone because again, they want a quick fix and they just want to fix that. And the lifestyle and underlying problems aren't addressed and they're just thrown a pill. I don't like to see that. So when that happens, I try really hard to kind of not take people off of it per se, but like backtrack and kind of get to the root source. But in better medication stuff, things that we're seeing that I see a lot are more dealing with like smooth muscle issue. So you might have things that they're doing like bladder infusions or treatments if like in terms of like helping with like the smooth muscle, like antispasmodics, if somebody has like overactive bladder, something like that. And so you're seeing like bladder antispasmodics. Very occasionally I'll see the use of Botox for that. And sometimes it's just because we're literally having to kind of break that pain cycle. So it's not like it's a kind of a constant like over and over thing. It's like a one time they're doing something to help to kind of break that cycle so that we can kind of move treatment forward. Those are the things I kind of see the most. I don't see a ton of like the gabapentines and stuff for this. Occasionally I do. I see some people on, the betas occasionally if they're kind of trying to think like there's like a really heavy mental or like anxiety component related with it. But I don't see as much of that as I think we used to. But I don't see a ton of patients that have like that level of chronic pain. There are a number of medications I see with my older folks that they prescribe to try to reduce like nighttime, like nocturia incontinence, which honestly don't seem to help a lot. And so for a lot of people, those wind up having more side effects. And so we try to then here deal with more of like the lifestyle factors, like cutting water off a little bit earlier in the evening and other things. Sometimes they help, sometimes they don't, but the nocturia is where I see a lot of medications thrown at people. One thing that's non-medication related, but, and I don't know if you know about this, but that I see the urogynecologists prescribe a lot, but it's a form of electroacupuncture and it's called PTNS. And they actually put the acupuncture needles down in the tibial area and they're stimulating the peroneal nerve that has a kind of a backflow up to the pelvic floor and bladder. And they do treatment generally like once a week for about 6 weeks. And it's not medication, it's just electroacupuncture. I actually see a lot of benefit with that for a lot of people. The nocturia, pelvic pain, overactive bladder. I see that with a lot of people, have a lot of effect, but it's a non-medication treatment that I think that it'd be nice if more people knew about and more people knew to ask for in conjunction with the other treatments that they're doing.
How about, I know we're going to run short on time here soon. I just got a couple more questions. So what about, I've been bombarded recently for continuing education. I do dry needling, and I've been bombarded lately with pelvic floor needling. Do you do any of that? Have you seen any signs that that helps?
So the problem is California doesn't allow dry needling.
Okay.
So before I moved here, I did dry needling. I learned with Trevor from New Zealand. So I'm just having like a Trevor Montgomery, brain fog. Sorry, Trev. But I learned with Trevor, and I did a lot of dry needling in Minnesota before I moved out here. It's not legal in California, and I get the same bombardment as you. So honestly, I don't have a ton of kind of feeling about it because I love dry needling. I think it's a really great treatment option. I so wish that I could do it with my patients here, but California hasn't legalized it yet. So unfortunately, I just don't have a ton of experience with it with pelvic floor dysfunction.
Okay, fair enough. So finally, because this has been absolutely awesome, and I cannot believe an hour has almost gone by. If you had one piece of advice to give, well, let's make it two. If you feel like you need one for men and one for women, what would it be?
Honestly, I think it's the same thing.
Okay.
For both men and women, like we've already kind of established, this is such a stigmatized thing that people just either don't know that they need or feel too ashamed to ask for. Both genders. I think men more than women at this point. But I just really think that if people could kind of just get rid of the shame, realize that they're not alone, that this is an issue that everyone deals with, and find people like yourself, like myself, who are willing to treat them, have the expertise to do that, and just realize that they could have so many lifestyle changes, sexual health, their bladder health, less falls, better athletic performance, better breathing. I mean, such a myriad of improvements if they would just be willing to talk about this issue, admit that they have some problems, and accept treatment. I think that would move so many people forward. And so I just think that like seeking it out, seeking out the care and really kind of not accepting that this is just something that they can just throw a pill at and just really kind of doing that. I think that would really help a lot of people's lives.
I couldn't agree more. And I think that's a wonderful spot to stop. And again, Heidi, thank you so much. And I will make sure that your name and your contact gets out there for this program, because I'm sure you can help a lot of people that are suffering from this, from pelvic floor dysfunction. And I will make sure that they get your information. So thank you so much for coming on and talking with us today.
Well, thank you for having me. It's been a pleasure.
This is pelvic floor awareness. This is probably the most important exercise that you're going to do in this entire holistic approach to pelvic floor health. Now, we have 5 muscles that we need to learn to control, not only to contract, but also to relax. Many times when people suffer from pelvic floor dysfunction, it could be one of two or a combination of two things. A hypertonic pelvic floor, where that pelvic floor is actually always contracting and tight, or a hypotonic pelvic floor, where that pelvic floor is weak and loose. This particular drill is going to help you start gaining control of 5 major important muscles that deal with the pelvic floor. The first set of muscles is the pelvic floor itself. Now, the pelvic floor is made up of the obturator internus and the levator ani. That's very simplistic, but I'm going to keep it simple right now. And for you women, all I'm going to tell you to do is a Kegel. Every woman knows what a Kegel is. You're going to contract your pelvic floor. If you're a male, you might be scratching your head and saying, I don't know what a Kegel is. So for the males, I use a couple different methods. One method could be, I want you to literally lift your testicles off the chair, not with your hand, with your own power, okay? Another scenario I would give you was a suppository. Like if you put a suppository up your rectum because you're constipated, you're actually going to feel like you're going to draw the suppository up into your rectum. The third coaching technique I would use, which I don't like as much, but sometimes I have to use it, is if you're at a urinal and all of a sudden there's a fire and you need to stop peeing and run out of the building, stop to pee. So those would be the 3 commands I would use for my males. So Kegel for the girls, and those other 3 commands for the males. So now the pelvic floor, all you're simply gonna do is you're gonna contract your pelvic floor and you're gonna relax your pelvic floor. That's gonna be very easy for most of you. Once you can do that, you're gonna move on to the next set of muscles called the adductors, which are the muscles on the inner thighs. If you need to, you can put your hands like this and you can squeeze your fists. That's the contraction of the adductors. But you don't even need to do that. I can contract my adductors just by pretending like I'm gonna bring my knees together. So again, we have the pelvic floor so far, and we have the adductors. The third muscle group that we're gonna get control of is the glutes. And for the glutes, you're just gonna squeeze your buttocks. So if I squeeze my buttocks and I relax, you'll notice I get taller when I squeeze my buttocks, and I get shorter when I relax my buttocks. So that's the third group of muscles you're gonna learn to control by themselves. The fourth is your abs. Now for the abs, all you're simply going to do is draw your belly button in and then relax. Again, draw the belly button in and relax. And the fifth one is probably the most difficult, and that's why I put it fifth. If you don't conquer this one, it's not the end of the world. It's your diaphragm. If you stick your fingers underneath your diaphragm, and if you push up underneath your rib cage and push up into your diaphragm, and if you cough, you'll feel your fingers pop out. Well, you simply can contract your diaphragm and push your fingers out. So that's the contraction of the diaphragm. Again, fingers up underneath the rib cage, cough, you'll feel your fingers go out, or just simply push your fingers out with your diaphragm. So your first task is to own the contraction and the relaxation of those 5 muscles individually. Now, once you can do that, you are now going to start to combine, and this is where it gets interesting. So the first set of muscles you would combine would be the pelvic floor and the adductors. So here's what you do. Contract the pelvic floor, contract the adductors, relax the adductors, not the pelvic floor, relax the pelvic floor. Now remember, not only do I want a contraction, you gotta relax the muscles as well. That's extremely important because what we're doing is we're creating a gradient. We're moving the liquid in the body, and that's really important for people that are having pelvic floor dysfunction and that are in pain. So again, the first group of muscles is the pelvic floor. Contract the pelvic floor, do a Kegel, contract the adductors, relax the adductors, not the pelvic floor, relax the pelvic floor. Now, once you can conquer that, now we're gonna go pelvic floor and glutes. Contract the pelvic floor, contract the glutes, relax the glutes. Don't relax the pelvic floor, relax the pelvic floor. Many of you are gonna go, ooh, that's difficult. Yes, it can be very difficult. You need to do this in a quiet room and you need to focus. So again, the second group is pelvic floor, Kegel, glutes, relax the glutes, not the pelvic floor, relax the pelvic floor. The third is contract the pelvic floor, contract the abs, relax the abs, not the pelvic floor, relax the pelvic floor. Again, pelvic floor first, abs second, relax the abs, relax the pelvic floor. And then the next group would be the pelvic floor and the diaphragm. This one's tricky. Contract the pelvic floor, contract the diaphragm, relax the diaphragm, not the pelvic floor, relax the pelvic floor. Now, once you can get that group of muscles, so that's 2 muscles, guess what? We're gonna add in 3. So now the next sequence would be contract the pelvic floor, contract the adductors, contract the glutes, relax the glutes, not the adductors, relax the adductors, not the pelvic floor, relax the pelvic floor last. So now you're controlling 3 groups of muscles. So again, pelvic floor, adductors, glutes, relax the glutes, relax the adductors, relax the pelvic floor. And then we would simply go, the next one would be pelvic floor, abs, diaphragm, and then relax the diaphragm, relax the abs, relax the pelvic floor. So that is your challenge. And eventually what you're gonna be able to do is you're gonna be able to contract all 5 and release all 5 in sequence, like this. Contract the pelvic floor, contract the adductors, contract the glutes, contract the abs, contract the diaphragm. Relax the diaphragm, relax the abs, relax the glutes, relax the adductors, and then you release the pelvic floor. That is your eventual goal. It is not easy, but again, this is your body, you should be able to control every single muscle in your body. And this may seem like a really simple, stupid exercise, but I'm telling you right now, if you can gain control of all of those muscles with contracting and relaxing, you will definitely be on your way to pelvic floor health. Hello everybody, this section on a holistic approach to pelvic floor pain is all about breathing. But before I bring on Alessandro, who is a world-class breathing expert and right-hand man to Patrick McKeown, who is probably the most famous respiratory therapist in the world, I want to take a moment to preempt him with a few comments. First of all, breathing separates us from a dead person, and breathing affects every single biochemical process that happens in the human body. Now, there's no doubt that breathing probably did not cause your pelvic floor pain and dysfunction. However, if you do not correct your breathing pattern, if you do not focus on your breathing techniques and sequencing, this may lead into a vicious cycle, because a lot of times when people are in pain, they'll do one of two things. They'll either hold their breath or they will breathe too frequently. And that's what I see most often, is they hyperventilate. When we hyperventilate, all you have to think about is someone who is having a panic attack. It is not a very pleasant thing to witness or experience, because everything goes into spasm and everything tightens down. And if you are having pelvic floor pain, that is going to lead into this vicious cycle of pain. When we breathe too frequently, we actually gas off all of our carbon dioxide, and we create this big differential between oxygen and carbon dioxide. So we have way too much oxygen and way too little carbon dioxide. Carbon dioxide will actually help relax your body. So getting in a good breathing rhythm will do wonders for your pain. With Alessandro, we will talk a little bit about what I call the perfect breath, being breathing in for 5 seconds and breathing out through 5 seconds. By the way, the mouth has zero purpose for breathing whatsoever, and you should only breathe in and out through the nose. So a truly healthy person is only going to breathe anywhere from 6 to 10 to 12 times when at rest. So we want to go ahead and slow down your breathing. We also want to start using this thing called the diaphragm. The body is composed of 4 diaphragms: the cranial diaphragm, the cervical thoracic diaphragm, the thoracic diaphragm, and the pelvic diaphragm. And the pelvic diaphragm is the pelvic floor and why you are watching this video series. These 4 diaphragms work together, and when we use our thoracic diaphragm properly, it literally pumps and massages all of the internal organs. And as a matter of fact, the thoracic diaphragm is the second most important pump next to the human heart. So not only do we want to slow down our breathing, we also want to breathe diaphragmatically. That sometimes can be very difficult to do and easier said than done. So what I'm going to do here is I'm going to hit pause, and I'm going to take you all through a little sequence that I call breathing through the sequences of infant development. I'm Dan Hellman, and I'm really excited to bring to you a good friend of mine and colleague. And if I was Italian, I could pronounce his name really cool, but I can't. This is Alessandro Romagnoli. Did I say that okay?
It's okay, then go ahead.
And as we're speaking right now, or as this is being recorded, I'm speaking with Alessandro in Milano, Italy. And
Yes.
I met Alessandro a while back, where Bryce Turner and I brought him to California, and he helped us with the breathing workshop. And Bryce and I and all of the attendees were completely blown away with his vast knowledge. So Alessandro is a sports psychologist. He's a psychotherapist. He's an Oxygen Advantage and Buteyko Clinic master instructor and scientific consultant. He's a Wim Hof instructor, and he's a mindful sport performance and enhancement instructor. And he's also a writer. And I know he's doing a lot of amazing things right now. And I'm really, really honored that he's taken the time to talk with us today. So to start with, I want to just make a couple comments. The reason that we're starting this particular 120 days to pelvic floor health, the reason why we're starting with breathing is because I've always said, and my good friend and mentor Paul Chek taught me this from day one, is that breathing is what separates you from a dead person. And if you think about the survival hierarchy, we can go without food for months. We can go without water for a few days. but we cannot go without breathing for probably more than, what, 3 minutes max, maybe, before we start having brain damage. So no matter what we do in life, no matter what the pathology is, I think there's always a breathing component to that pathology. So with that said, I want to know what you have to think about that, Alessandro.
So, first of all, thank you, Dan, for the invitation. Dan told me that we are colleagues, but we are also big friends. So I'm super happy to be here and to share my knowledge with you and with you people that are watching from home. So bouncing back to your question about what separates us from a dead person, yes, breathing is one of the most important things. So if we pay attention to the literature, if we pay attention to the breath in general as a domain of investigation, the breath has been used many times in poems, in religion, in archaeology, and with many different interpretations and meanings. Also, something that I love is anthropology, the science of human groups and how they've developed along the time. So one thing that I love is also their interpretation of the word breathing. For example, if we pay attention to the Latin, the word breath in Latin is spiro, that can be linked to spiritum, spirit. So there is an association between mind and breath, but also vitality, energy. If we pay attention to the word qigong, which is qi, the breathing, vital breath, energy, and gong, skill, or meaning training. So actually breath work, an old way of breath work. So yes, from one side, if we don't breathe, we die. But on the other side, if we breathe well, we can also enhance our longevity and quality of life. Because in my opinion, and based on several scientists and literature, when we breathe well, we can still deal with the quality of our life. For example, working in pneumology or people in very bad breathing conditions and clinical pathological conditions, they have a hard way to breathe and recover. So you have other citations like we have two fundamental breaths in our life, the first and the last one.
And the last.
And the last. Or otherwise in yoga, there is a sentence that says that we can count the number of years that we have in terms of breath also instead of years itself. So yes, it's breathing is what separates us from a dead person or an ill one also.
Sure. And then again, breathing, then maybe you can expand on this. Breathing, because there's this relationship between oxygen and carbon dioxide, and I think you'll talk a little bit about that. Breathing truly affects every single biochemical. I know there's a biomechanical approach to breathing, the proper way to breathe, et cetera, but can you just touch loosely? I don't want to get into chemistry, big chemistry terms and stuff like that, but breathing truly affects every biochemical process in the human body. Would you agree with that?
Yes, totally, for different reasons. So first of all, we mistakenly tend to consider CO2, carbon dioxide, as a waste gas.
Yeah.
It is not. It is not. Because based on the studies of the Danish physiologist Christian Bohr developed the Bohr law, which means basically that the higher the CO2 levels, more oxygen will be released into the tissues, from the hemoglobin to the tissues. However, on the other side, if you don't have enough CO2 around the hemoglobin will just keep the oxygen molecules into itself and won't release everything. So it won't promote any kind of oxygenation at all from a biochemical perspective.
Yeah.
However, there is another thing to consider is if you're exhaling too much, let's picture out something together. If you are doing some sport and you are performing, for example, you're going to exhale a lot through your mouth because actually CO2, it's what gives you the sense of air hunger. Sure. You're not suffocating because you're losing oxygen or you're depleted in oxygen. You are gassing out because you are actually having a lot of CO2 production due to any kind of biochemical compounds and disgregation and food degradation, and this is why you produce a lot of CO2. But combined with movement, you're going to produce a lot of CO2 and exhale a lot, because inside the CO2 is a gas, but into the body it turns to be acidic, and it turns your body to be acidic. You know that we have a pH. Our body can be acidic or alkaline.
Right.
Keeping all that CO2 inside ourselves will bring our body to be more acidic. In the meantime, it will help our body also to release more oxygen into the tissues. And also, one last thing is from a neurological perspective. Into our body, like fire alarms, we have chemoreceptors that are kind of fire detectors, the one that you have in your kitchen. Right. However, if your chemoreceptor is very sensitive to CO2, it will trigger to the brain, it will send a signal to the brain will sense it, and will trigger the ventilatory response every time. So if your chemoreceptor is too sensitive, you will tend to hyperventilate, and your alarm is too sensitive. So what we have to do, it's very simple. We have to train our body to resist or to tolerate higher CO2 levels without suffocating, of course, but just to be trained like this.
Sure.
However, CO2 has another thing for me, which is, and the last one, really important, it's also a vasodilator. So more CO2 you will have into your body, more your blood vessels will tend to actually vasodilate and promote the blood flow into our system and metabolism.
And I was going to talk about this after this next question, but I think it's probably a better segue into another question that I had a little bit later, but that has to do with pain. I know from my patients that have had pelvic floor dysfunctions and pelvic floor pain, that's a very sensitive area down there, right? For men and for women. And can you talk a little bit about, how breathing can either feed into the pain? For example, we've all probably seen someone have a panic attack, and it's not a very pleasant thing to witness. It's not a very pleasant thing to have. I've had a couple in my life, and you think you're going to die, basically. How does the breathing dysfunction, if you don't have good levels of CO2 and good levels of oxygen, if their ratios are way out of whack, how can that either feed into the pain that the person's presently having? And more importantly, for those people that are watching this, how can that maybe take them out of or help them with their pelvic floor pain?
Okay, so we're going to cover, I will try to be very synthetic in my explanation, but you are talking about physical pain, and I will rely on my experience on psychological pain. However, pain remains pain.
Pain is pain.
Every time. Pain is pain. There is nothing to do. It is considered as an unpleasant sensory or an emotional experience in general. And we attribute then, after that sensorial experience, the notion of suffering, okay, which turns to be an interpretation, well-founded, grounded interpretation. But nonetheless, as an emotional outcome, let's imagine you talked about panic attacks. And one of the symptoms of the panic attacks is the sensation that you're going to die. Okay. And I saw this many times on different patients. Tachycardia, so your heart start to boom like never, or the sensation of breathlessness, that you're suffocating. Suffocating. So what happened during the panic attack? I would use the pain as an bad emotional outcome, fear, because what characterized the sensation of panic attack is fear. This is the main emotion that is experienced. So the limbic system is actually triggering a lot of scenarios into our mind, or there is something in our environment that triggered or reminded us something terrible about the future, maybe, or something about the past, who knows? And we start to have a racing mind. You can imagine the slide, the PowerPoint slide that keeps on rushing like never. And you believe that you're going to be crazy at a certain point. In the same time, the body, and from a neuronal aspect, the respiratory system just behind our neck, in the trunk, in the medulla oblongata, start to fire too and have a lot of hyperventilation reaction. And we start to react because emotions triggers a specific emotional pattern. I'm happy, I will scream, I will breathe in, open my mouth. If I'm scared, I will try to, if I control myself, I will try to suffocate my scream or so else. So the pain will trigger a certain breathing reaction. This is the ascendant pathway. Like when we stamp on the Lego, for example, we feel the pain goes to our brain, and then the brain, we want to scream because the limbic system is triggering a lot of reaction, motor reaction. Also, the first behavior that we're going to do, thanks to the ascending pathways, to remove our foot from the Lego. But on the other side, what happened then? The descendant pathway, which is more related to the pain management, to the clearing out the tissues that have been broken, or to recover from an emotional perspective and psychological perspective, so to settle down. So from the behavioral perspective, after we have done something, we're going to scream, or when we are scared, we're going to scream. But this is the place where we lie the solution. We can use the breathing to calm down also and to ease the pain. I love I forget the name of this French doctor about, I think his name was Lamazé or something like this. Maybe I have it in the notes, where he used to teach to pregnant women a breathing way to solve and to reduce the pain associated with the movement of giving birth, because not only your body, once you're feeling some pain, is going to trigger a lot of opioids for coming down and ease the pain, but also to recover in a certain way. But if you use the breath and the way how that French doctor, I don't remember his name, that's a big deal, but we're going to cover the solution very back. So what happened? While using another way of breathing, in this case, for that French doctor technique was to breathe in and to breathe slowly through the mouth. And again, or breathe in. And when the body feels to breathe in another way, to just do some kind of shouts with your mouth. Because those kind of breathing will help you to deal with the pain and also to gain in confidence. So every time the physical part to calm the pain, but also to reposition ourselves in front of the pain and adversity. Same thing with the Wim Hof method. For example, chronic pain, it is a pain that can last from at least 3 months and beyond 3 months. It can be intense. It can be from a moderate intensity to a low intensity. It's not this is the main problem, but some diseases are autoimmune because it means that the cytokines, the cells in movement that are involved in dealing with pathogens, are attacking the body. So we notice with the Wim Hof method, for example, and other breathing technique, that you can enhance the response of those opioids and deal with inflammation by calming down the inflammation, and also promote pro-inflammatory cytokines. I will finish with that example. If you do 6 breaths per minute, 5 in, 5 out, then the vagus nerve, the one that starts right underneath the medulla oblongata, the breathing center, and connects with all your organs, just by doing 6 breaths, you will increase the traffic of the vagus nerve. What do I mean by that? You're going to promote a huge release of anti-inflammatory cytokines, and it will help you to deal with the pain. I remember this episode, it was with Bryce and you, I don't know if you remember, with that gentle lady who had Parkinson. She was moving every time. And after, with you, just in front of us, I'm not kidding, Dan was here, Bryce too. We look at that lady, she was doing 6 breaths per minute. She didn't have those kind of neuromuscular behaviors that are characteristic of Parkinson.
It was amazing. That was a great explanation. So let's move on then to the question I was going to go to is, and this is, I think, very important for pelvic floor, is when we do breathe properly and we move the diaphragm. I was always taught that the heart is the greatest pump in the human body, but the diaphragm is the second greatest pump. And that if we can make that diaphragm move in its totality, that we literally pump and massage the internal organs. Can you expand on that a little bit?
Yes, we are entering now. So altogether, what we did do so far, we divided the breathing system in 3 dimensions: the biomechanical part, the biochemical part, and the psychophysiological part. Now we are diving into the biomechanical part. So here it's pure physics. And when we talk about physics, we talk about gravity. This is one of the most taken for granted factor, but it is one of the most important because also the breathing mechanics is relying on the gravity factor. So in our case, why, for example, while breathing in, we use the biomechanics, so the tissues, the lungs, the diaphragm, in order to promote and do certain movements. I imagine I'm figuring out as an example, the deadlift. We breathe in, we compact everything into our core, we use the core, we tighten up, and then we lift the heavy weight that we have underneath. Or, for example, and another thing is when we are actually doing a deep breath, we have that sensation of well-being that accompany us, not only because we are also releasing some opioids, for example, but we are also stretching ourselves just a little bit, just to have some space and increase the thoracical pressure and intra-abdominal. So yes, let's go back to the diaphragm. The diaphragm is an asymmetrical muscle. So the diaphragm, D from Italian or Latin D, which means two divided in two. The diaphragm divides two segments. This is what the diaphragm does because it surrounds our vertebral column and help us to maintain a good mobilization of the vertebral column. So if your breathing is dysfunctional, you will tend to loosen up that stability. This is why it is important to have a good diaphragmatic situation and status. On the other side, it's as an asymmetrical muscle, breathing muscles, because on one side you have the heart that lies actually on the diaphragm, underneath the liver too. So breathing normally and having a proper and functional breathing will help your diaphragm to massage a little bit your heart, for example, while breathing normally. Because if, for example, you're breathing dysfunctionally, you will tend to vasoconstrict and you will bring some pressure over your heart. And I'm thinking about also sleep apnea or snoring. So, and you can increase your hypertension by 150%. This is why a lot of people can die from this during their sleep. So restoring a proper functional breathing is important not only for your biomechanics, but also for your cardiovascular system and the blood flow. While holding your breath, a lot of blood is rushing into your brain. If it's done voluntarily for a specific purpose, it's okay. Otherwise, if it's not done voluntarily, you can risk many things. And for finishing also your question and concluding it, we can consider also the lymphatic system. So all that kind of immune defense that help our body to cope with different pathogens. In yoga, they were really keen on it because using the gravity, so for example, putting yourself upside down with vertical position, you can also bring the lymphatic system everywhere into your body and plasming your body into it and promote the activity and also release and detoxify your body along the way.
Fantastic. So we know, and I think I talked to you about this when I met you in California, and I talked to my friend Paul Check about this, is that I was on an island assessing a bunch of islanders, and let's just say I assessed 50 people. I maybe found 2 people that had a normal breathing pattern out of those 50. And when I told this to Paul, I said, I must be doing something wrong because everybody's got a faulty breathing pattern. And he just chuckled and said, no, that's very normal. There's a lot of physical reasons why, and you and I talked about this before we jumped on the call. You know, today's world of sitting and cell phones and everything going down, visceroptosis, compressing of the lungs, compressing of the diaphragm. But then there's also that big emotional, mental, spiritual capacity, because we have 9 times more neurons in our gut as we do in our brain and our spinal cord. So whenever you get scared, mad, or upset, you feel it in your gut, and you tend to create a holding pattern. So for all of you that are participating in this course, I can say with a 98% probability that you probably have a bit of a dysfunctional breathing pattern yourself, especially if you've been suffering from pelvic floor pain and things like that. So with that said, Alessandro, is there an easy way that you can maybe, well, first thing, how should we breathe? Okay, number one. And then number two, maybe can you take us, is there a breathing reset protocol that you could show us that might help people to start breathing the right way? Because, you know, we have paradoxical breathing, we have people that are neck breathers, we have inverted breathing patterns. I'm sure you know a lot more than I do. So maybe if you could do two things, if you could maybe talk to us about what normal breathing is, and then maybe show us a bit of a breathing reset protocol that you might know.
Of course, it's not a problem at all, with pleasure. The first thing that we have to do is we have to, as all the things that we are facing in our everyday life, we have to measure if we are improving something that we are practicing. What do I mean by that? This is why we have to learn how to test actually our breathing system. So let's start with the quality check. The quality check is a very simple way to tap into your breathing. So I'm going to invite you to put one hand over your chest and the other one over your belly. That's it. You're going to close your eyes. And from a breathing perspective, I just want you to bring your attention over your breath. If you're distracted, it is okay, because we are trained in our everyday life to be distracted, but just bring back your attention. And if you notice that you're distracted, just bring it back once again. Do not judge yourself. This is the most important thing. And try to sense, as if it was the first time for you in your life, to sense all the sensations related to the breath. For example, the air flow passing through your nostril. While you're breathing in, you feel your nostrils, the cold air passing through your nostrils. And while you're breathing out, you feel the warmer air going out your nostrils. And try to widen up a little bit those sensations. Be more sensorial than mental. And try to feel the sensations of the breath, maybe into your biomechanics, the tissues, maybe your diaphragm or your lungs. While breathing in, you feel your diaphragm inflating, your belly inflating, or your chest. We're going to correct that later. And while you're breathing out, you feel your breathing mechanics going in. Try to be curious and bring your attention also in your back, if you can. And feel also the effect of the breath into your back. And now, we'll put the physical and biomechanics in the background. And I'm going to invite you to bring your attention over your mental activity. How is the state of your mind right now? Are you thinking a lot? Do you have a racing mind? Or maybe you're having a sensation of space, or a good emptiness, or neutral, totally neutral. This is your way and how you relate with your breath right now, from a psychophysiological perspective. And then, from an emotional perspective, how are you feeling right now? Neutral, peaceful, a bit happy maybe, or angry, irritated, nervous. There are no wrong emotions. This is the way how you deal with your breath and your breathing quality. Open one eye, open the other. Can you give me your sensations then?
Yeah, so right away I was tuned into the hand on my belly moving. And then as we were doing that, of course, you know, preparing for this, my mind has been racing. But as I was going through that, when you said, "How do you feel?" I was going to say, "I feel friggin' great." So I felt really good emotionally doing that drill.
Yeah, super. Some people can feel irritated because some people don't like to stop.
Sure.
This is normal. This is another way to experience things. However, this is the quality check. It's also a good stop for your day just to settle down. And now we're going to correct some biomechanics, but I have an additional test to you, which is the BOLT score, body oxygen level test that has been implemented by Tom Herron and Patrick McCuen, for a director of the Oxygen Advantage and Buteco Clinic. And the BOLT score works like this. I want you to do a normal breathe in and then followed by a normal breathe out when I'm going to tell you.
Okay.
Be careful about one thing. It's a normal breathe in, an everyday life breathe in. It's not a full breathe in and a full breathe out. And everything has to be done through the nose.
Okay.
And we're going to do it together. And whenever you want, do a normal breathe in, a normal breathe out, and pinch your nose and hold your breath. And as soon as you feel the first sensations of constriction to your diaphragm or throat, or the first desire to breathe in, you just breathe in. You don't do a long breath hold.
Okay.
Super. 24 seconds. So your BOLT score is actually a good assessment of your breath. So what the BOLT score is telling me right now, it's that between 25 and 23 seconds, you have a correct BOLT score, but you have a good room of improvement. It means that your breathing is correct, that your breathing is answering to your metabolic resources and exigencies as you are breathing in your everyday life. But on the other side, if the BOLT score is below 20, it means that your breathing is dysfunctional, but there is room for improvement in such case. So we have different techniques. So what are the techniques now in order to help you? I want you to just put one hand on the opposite shoulder and the same for the other one. And while you breathe in, I don't want you to breathe through your shoulders, but I want you to breathe as much as you can through your diaphragm. And I just want you to breathe this way. When you breathe in, you feel your elbows going forward. And when you breathe out, you feel your elbows going backward. Breathing in and out. We're working on the biomechanical dimension.
That's a nice technique.
It helps you to avoid any kind of upper chest breathing.
Yeah.
Because if we breathe too much through the chest, we activate a sympathetic reaction, and we tend to have and to elicit anxiety phenomena. And now I'm going to invite you to put your hands over your lower two ribs and still keeping your shoulders relaxed. I'm inviting you to breathe as much as you can from your diaphragm. While breathing in, you feel your diaphragm expanding. And while breathing out, you feel your ribs going inward. While breathing in, you feel your ribs going outward. And while you're breathing out, you feel your ribs going inward. If you feel that your fingers are getting close to each other, it means that your breathing mechanics is working properly. Your shoulders are relaxed. Remember that behind the lower two ribs, we have the diaphragm. And when we breathe through the diaphragm, we release a lot of acetylcholine, which is the antagonist of cortisol, the stress hormone. And now, put your hands over your lap and try to continue the same breathing pattern while doing this. And keep breathing through your lower two ribs. If you're breathing in, you feel your ribs going outward. If you're breathing out, you feel your lower two ribs going inward. In and out. And now we're gonna go and dive into the biochemistry dimension. And I want you just to pinch one nostril. And while doing this, I want to trigger you a small air hunger. I want you to breathe at 80% of your capacities. If you're tired with one arm, you can switch arm if you want. And you'll see that one sinus is more stuffy than the other one.
So just breathe 80%.
80%. You have to stimulate a certain sense of air hunger. And remember, also for the people at home, that air hunger is triggered by the levels of CO2 that you're containing right now. This is what you're feeling. This is what is happening. CO2 levels are contained. This is what gives you now the sense of air hunger. I'm half French, so we can use the moustache technique just below your nose, the moustache, as we say in French. And I want you to reduce the airflow over your finger. Now you're normalizing also the biochemical aspect of the CO2 levels into your body. It gives you also sensations of relaxation. The blood vessels are dilated. This is why the body temperature might be a little bit elevated, warmer than usual. You can feel it into your hands. Okay, put your hand on your lap. Let's finish with the psychophysiological dimension. We're gonna do just 6 breaths per minute. And let's do this. Let's breathe them together. In, 2, 3, 4, 5. Out, 2, 3, 4, 5. In, 2, 3, 4, 5. Out, 2, 3, 4, 5. In, 2, 3, 4, 5. Out, 2, 3, 4, 5. And keep going like this for 4 breaths like this. But just keep on keeping your breath light, stimulating a certain air hunger, and breathing with your lower 2 ribs. While you're breathing in, you feel your ribs going outward over 5 seconds. And while breathing out, you feel your lower 2 ribs going inward for 5 seconds. And now restore normal breathing. And whenever you want.
That's fantastic.
Here we are.
Yeah, that's a great reset technique. Thank you for that. Beautiful.
This is my job, and this is my pleasure.
So just maybe some simple questions now. So should we breathe through our nose or should we breathe through our mouth?
So this is why we advise to everyone. This is why what Patrick McKeown advised. This is what literature advises usually. It's to breathe through the nose during the day and also during the night. So this is why during the night you can apply a myotape. If you're scared, don't worry. You can have a scarf, the head scarf around your head. It's not very beautiful. It's kind of awkward somehow, but this is in order to promote nasal breathing. Of course, my advice is way to have a bold score around 15 and 25 if you want to do such a thing. Otherwise, if you apply it and you have a bold score of 6 and you have 6 seconds and you have a dysfunctional breathing, you can elicit a headache in your head in the day after. So the main purpose is to breathe through the nose for the following reasons. The first one is air is filtered. All the pathogens are filtered through the air that you have into your nose. And then the mucus that you have is also useful to take all the dust and to remove all the free radical that may enter into your metabolism, because the nose is really exposed. And this is also an totally open airway that goes directly to inside your body. So this is why we have a huge system of defense mechanics just inside it. Sure. Then I can imagine many people have received a kick into their nose, and you can see how much you can bleed. So why? It is hypervascularized in order to warm the air going in to your body temperature. If, for example, you breathe through the mouth, not only it will make your mouth totally dry, you can breathe through the mouth for 5 minutes and you will see that your mouth is totally dry, but at least over 500 milligrams or 500 milliliters of oxygen, at least 150 will remain over the tongue and the throat while more oxygen will be absorbed into the nostrils and diffused into your air sacs, into your lungs. So nose breathing, also for the last one, the last reason, which is important, just right over here. So between your nose, on each side of your nostrils and between the eyebrows, you have the paranasal sinuses that are filled with nitric oxide, which is a vasodilator, antipathogen, antiviral, and you can trigger, we're gonna see an exercise later, in order to trigger the nitric oxide. And when, for example, you have sinusitis or a stuffy nose, that will help you to remove the stuffy nose, the stuffy material, or organic material, and free your pathway. So this is the main suggestion. Also, while doing physical exercise, nose breathing. If you're a competitor, our advice is breathe spontaneously, because focusing on your nose while performing can be distracted. If you're a competitor, you need all your attentional resources to deal with the challenge that you have ahead.
Okay. And then, and we've talked about this briefly, but how many times a minute, what's the range of breathing per minute for healthy people?
For healthy people, usually we breathe more or less 20,000 times a day. Of course, it can oscillate because of different environmental factors or internal factors like emotions or bad memories or whatsoever. So per minute, what we advise is to breathe between 12 to 15 breaths per minute. This is what the literature is also advising. However, if the number of breath that you do in 1 minute, it goes beyond 15, it will be just a muscular and neuronal reaction that is totally will pump in an empty way. It won't do much. Instead, it will just elicit panic attacks or hyperactivation reaction. This is what we don't want. You have certain techniques that helps you to do that, but in your everyday life, we want a proper breathing with as little breathing of breath as possible, between 10, 12, 15. This was an advice gave by the 1990 literature in pneumology.
And then before we forget, the Oxygen Advantage, they have an app. It's a free app, correct? And
yes,
on that app, you can track your Bolt score, correct?
Yes, you can track the Bolt score, and then you have a series of exercises based on the Bolt score. So this is what is suggested by the app, but you can also, for example, choose what kind of skill you want to develop. Focus, if you want to enter in a flow, not only while performing, but for doing sport, but also while working. When we are in the flow, we're full of ideas. For coming down, for settling down, to perform, to get out of our head. This is a super fantastic exercise. I love it. When you're overflowed by many things, you have the racing mind. Oh, we're going to see it later if you want. This is a free app. You can also have some exercise for the kids, for asthma management, panic attacks.
Wonderful.
So you have plenty of exercise.
Okay, and then let's start closing up this talk with, I was wondering if you could leave us, and the viewers of this program, if you could leave us with a few of your favorite breathing techniques or exercises that, hey, I'm having a bad day, my pelvic floor pain is really bad. Is there some breathing techniques that you can teach us that might help with that pain? I mean, I know we talked about, box breathing, but that might be a little aggressive. What are some techniques that you might be able to teach us here and leave us with?
Okay, if we want to deal with pelvic floor, we can also do this exercise maybe on a chair. It's something doable. So we have different exercises. The first one is we can put our hands over our chest and just do a very simple breathing. I just want to imagine that you have a tail and to tuck your tail over the chair just temporarily. And when you're breathing in, you feel the diaphragm going down and you feel yourself inflating. While breathing out, you release your shoulder. This is a very easy exercise to do. And then we breathe in, we lift our shoulders And we breathe out. Keep on tucking your tail. And then once again, we breathe in. And we breathe out. And now we're going to do the opposite movement with our diaphragm. We're going to fully breathe out through the nose. If you feel comfortable through the mouth, it's okay. It's not a problem. And then we're going to lift our elbows. So what we're going to do is deflate yourself, exhale, and then hold your breath, lift your elbows. Bring your belly button in and contract your glutes, and then breathe out, relax. And once again, we exhale totally. We lift our elbows. We pull our belly button in. And we recover, we breathe in. Let's pause a second. We breathe normally for a couple of breaths. Same thing, once again, we breathe out. We tuck our tail, belly button in, we lift our elbows. And we breathe in, we go down one last time. We breathe out, belly button in, we lift our elbows. And we recover. This exercise.
Yeah, that one was interesting because it's you reverse it at the end, and it's a little bit of a mind game.
It's a mind.
Yeah,
it's a mind game in the end. You have other exercises similarly where you can hold, for example, I have only one drink over here. Well, let's imagine that's 2 kilos kettlebell, and you hold the kettlebell like this. You breathe out, and you hold. You pull your belly button in, and you switch from one side. You switch to the other, and you recover. Of course, the weight has to be not so heavy if you want to keep a good posture. Those exercises can be the same way. For example, if you just breathe out and you are on the floor, you can be on the floor and you can lift your hip, bending your knee, lifting your hips. Unfortunately, I don't have a lot of space here, but also doing the same exercise while breathing out, bringing your belly button in. The most important thing is to bring your belly button in, just to not only for a question of biomechanics, but also of proprioception, to stabilize the good connection, neuronal connections with your core, because the core is not only the abs. You are the physiologist here. I'm just a mentalist, I like to say psychotherapist.
Can you talk me through that one again? So if I have two objects here, I'll just hold them.
Here, you hold. Just open your chest as much as you can. Okay, super. The chin is just facing forward. You're facing forward. You're actually breathing out totally. You bring your belly button in. I can talk. And on the other side. And you recover.
That's a nice little stretch.
Yep. And you have the last, for me, this is one of my favorite. This comes from the world of subdiving, is you will keep a strong pressure. Of course, you have to be aware that if the client in front of you or your patient doesn't have any kind of ribs injuries or any kind of back problems. So what you can do is you will have to keep as much as you can the strength and the firm grasp over your lower two ribs. And what you're going to do is the following things. You're going to breathe and then gently breathe out. And you will keep the pressure over here. And then you're going to breathe in once again deeper. And you'll keep the pressure just right over there. And you breathe out. And then you put your hands even further. And you're going to breathe in. You keep the biomechanics, I don't know if you're seeing that, but I have some tremors in my shoulders.
Oh yeah.
And you breathe out and you keep the pressure just where it is. And once again, we breathe deeply this time. And stay there. You hold for 3, 2, 1, and you let go. And more you're doing on this exercise, more you're working on the volume. My advice is, I'm a technological guy. I love gadgets. You have also the AeroFit, the one that helps you to hyperventilate, to also control, to strengthen your inspiratory muscles or the expiratory muscles. You have a lot of things also with those gadgets that can help you to structure and also to reinforce all the breathing muscles and the biomechanics that are working around it.
Do you have a favorite technique? Say I've been in a pain pattern for a while and I'm hyperventilating, I'm breathing, 25, 30 times a minute. Do you have a favorite technique that you can teach us that might help slow down and more normalize that breathing pattern? So we're not, because, as we talked about, the more you hyperventilate, the more things tend to spasm, the blood vessels constrict, we're not getting blood flow to the areas we want to get it. So do you have a favorite technique that you would share with us that would maybe help more normalize that breathing pattern?
Allow me to be a poet just for a second. I'm a martial artist. So usually in martial arts, what do we do? We use the weight of our opponent against him. So this is the same philosophy that I apply also to the world of breathing, pain management, emotion management, which is, for example, you are in pain. We use the emotion online and you feel the emotion. The emotion itself has something to say and something to enact. You're angry. You received a very bad news. You want to destroy the world. My advice is scream. The first thing that I do with as a sports psychologist, with professional fighters, professional soccer players, fencers, etc. You don't feel you're happy and you've targeted something, you had a point, scream, move that emotion somewhere else. Because if you keep it inside you, it will somatize. You will have psoriasis, you will have tension, and you will increase the risk of injury. Scream. The emotion has something to say. Scream. You want to cry. Scream. Scream on this purpose, because while screaming, first of all, bring your attention in this zone of the brain. Because while bringing your attention, you are actually having an electrical connection. Attention is also bringing an electrical connection with the muscles or a brain area. Just bring your attention over that place. Scream as many times as you want until you're tired.
Sure.
Until you're tired. This was one of the main techniques used in the world, in the old methodologies of breath work, but it works. It's a good way of managing things. You need to scream. For example, with surfers, I will ask them to scream into water before championship. With, for example, another guy who is at home and we're doing some kind of sessions, online sessions, scream into the pillows until you're tired, first of all. Then there is another nice technique that I love, which is called...
Well, can I just make a comment on the scream?
Go ahead.
I've done my best screaming in the car. I've had some challenges lately, and it's funny. I've had some emotions come up in me when you were talking about the screaming, because I've had some days where I've driven home from work and I've had to, before I was getting to my destination, I've had to let out some screams, and it's really amazing how well that technique works.
Yeah. Because this is the thing that I love it. I'm sure that you experience the same thing, which is you scream, you have the pick of your emotions, you have the emotional pick, you're screaming as hell, and then you scream as much as you want, as you feel like, not as your mind is saying, yes, I have to scream at 2 p.m. No. You have to learn how to sense yourself to scream. And then you scream. Once you scream, then you enjoy the silence after the scream, which is really important. This is the moment of the opioids that are released into our tissues, into our cells. Then there is the get out of your mind exercise that I love for pain management, or also for getting out of your mind while you are in a rush. It is something that particularly I like. It's a quick hyperventilation that will slow it down for you people, because it can be, you can fill your head easy. That's normal. You won't faint at all. We are going to be slow. We're going to breathe in belly, chest, head forcefully, and then exhale normally, with flow, without effort, effortlessly. So we're going to breathe in and then breathe out effortlessly 20 times. After the 20th times of our breath, after the 20th breath, we're going to exhale normally and hold our breath as much as we feel like. As soon as I feel the good sensations and I see that I have to hold too much, I'm not feeling okay, it's time to breathe and to reset.
So belly,
I'm gonna guide
belly, chest, head, 20 times.
And you let go.
Just let it go. And then on the last one, you're going to hold your
Yep.
breath until whatever you feel comfortable with.
Exactly. And you can do that cycle many times. It's a Wim Hof-like technique, but it's more, I like to say, more gentle and appropriate on certain aspects. However, do this technique if you feel like doing while laying down. You can lay down. If you feel like doing this technique against the chair, you can do it. It's not a problem. Just be safe every time in a safe environment. This is my main advice.
Wonderful.
So
I'm gonna ask you one more question.
Go ahead. I'm here for this.
I'll restate that. I don't want us to take your time for us doing that technique. So again, it's belly, chest, head, let it flow out, and you're gonna do that 20 times. And then on the 20th time, you're just gonna hold your breath until you feel like you need to let it go.
Exactly.
Okay.
But anyway, I'm gonna guide you. So close your eyes. Close your eyes and get ready with this breathing technique. And let's start together. And let's start to breathe into your ribs, to your belly, to your chest, to your head, and you let go through the nose. And again, breathe in belly, to the chest, to the head, and you let go. Super. And again, belly, chest, head, and you let go. Super. And again, belly, chest, head, and you let go. And you can feel some kind of tingling sensations, belly, chest, head, and you let go. And again, belly, chest, head, and you let go effortlessly. And again, belly, chest, head, and you let go. And again, belly, chest, head, and you let go. Super. Let's keep going. Belly, chest, head, and you let go. We are halfway through it. Let's speed it up. Belly, chest, head, and you let go. And again, belly, chest, head, and you let go. You're in control. Don't worry for this. Belly, chest, head, and you let go. And again, belly, chest, head, and you let go. And once again, belly, chest, head, and you let go. And one last time. Belly, chest, head, and you let go, and you hold your breath. You hold your breath comfortably. Observe what you're feeling in this moment without judging yourself. Tingling sensations, sensation of space, hot temperature. And whenever you want, you can stay there, breath holding comfortably. And when you say it's time for you to recover and to breathe in, just breathe in, but keep your eyes closed. Yeah, super. Well, let's do a simple exercise for 1 minute. Keep your eyes closed. Even 10 seconds. Try to breathe light, as we've done earlier. To keep your breath so light that you stimulate a sense of air hunger. You don't feel the turbulences of the airflow in and out through the nose. And whenever you want, open one eye, open the other.
That's fantastic. Wow. One last thing, and I don't mean to put you on the spot, but I think I told you I was going to talk to you about this. I'm going to hit pause on the recording, and then I'll resume the recording in 1 second. So let me hit pause. So Alessandro, I brought my table in. I just didn't want to have to move my camera and get down on the floor. But some pelvic floor issues are due to visceroptosis, where you have a dropping of the viscera. And again, that can be due to excess body weight. It can be due to nutrition issues, can be due to, again, cell phone use, the upper cross syndrome, where everything has been dropped forward because we're always on our phones and our head is forward of our body. There's a technique that I'm going to be teaching everybody in this program where you're going to be kind of an inverted position. And you mentioned this earlier in yoga, how you can invert yourself, and that can do a lot of good things for you. That's why the yogis do that. There's a technique that I'll be teaching them where they're kind of in an inverted position. I'm not going to take them into a headstand, but I would imagine that if you could do a headstand, this would be even more effective. And because of all of the links with the diaphragm and the viscera, that when you're in the inverted position and you're really focusing on the exhale, because when you exhale, as we know, the diaphragm rises up, right? And so if I put myself in the inverted position, do you have any techniques that you could suggest that if I'm just like this in an inverted position, where I can work on my exhale, and that exhale driving my diaphragm up might help? And this is being really kind of crude and in a very linear way of thinking, but pulling the viscera up with me and with the diaphragm. Does that make sense? Like, I'm literally, a lot of people have prolapse, the uterine prolapse and things like that, where the uterus has dropped down, the ovaries, etc. And now I want to use the diaphragm to pull everything back up again.
So even if I'm not a physiologist, I can use the knowledge of and the physics of the breathing system in order to help you to strengthen the diaphragm. So what we're going to do, I'm going to ask you to breathe out as longer as possible until you reach a level of no air, where you have fully exhaled everything. I want you to hold your breath as much as you can.
So breathe out as much as I can.
And then you hold your breath as much as you can.
Yep.
And I want you to feel your diaphragm contracting. I want you to feel your diaphragm tilting many times. You will feel some kind of contractions while breath holding.
That's pretty powerful in that position.
Exactly. But this is what we want, because from one side, more blood is rushing to the head. But on the other side, your diaphragm is getting more strengthened. You're training your diaphragm to be more resistant. So whenever you want, you breathe out slowly, until you reach a level of breath hold and apnea, and you hold the apnea as much as you can.
Ooh.
Yes.
Yeah, that's pretty powerful in that position. You know, I just thought of something.
maybe maybe doing some of the primal screams in that position might be
Stay there.
a huge thing too.
Stay there. There is a thing that I like to do is also this one. One, for example, I've done the exercise of get out of your mind. Just sit down on the edge of the bed. Then, thank you. So what you can do is you do a normal breathe in and a normal breathe out, and you hold your breath. You can hold your breath with your finger, or you can just hold your breath. I just want you to put also your hands, if you want, over your lower two ribs while breath holding. And when you cannot hold your breath anymore, you will feel a lot of contraction before. When you cannot hold your breath anymore, I want you to do 6 shots of air through the nose. 1 inch, in, out, in, out, in, out, after the breath hold.
Okay. So in, out, in, out.
Super. This is a level 1. The technique that you've done now, it's a level 2. I would like to say it like this, to categorize it like this. So the first thing to do is to do it together. I would like to ask you now to do a normal breathe in and a normal breathe out. And you hold your breath. And I want you to hold your breath until you feel several contractions into your diaphragm. When you cannot hold your breath anymore, you do 6 shots of air. Super. Did you feel the contractions?
Oh, yeah. Yeah.
Okay. The contractions that you're having are actually your chemoreceptors that are sensing that there is too much CO2. The brain is sensing that and is saying to the diaphragm, come on, diaphragm, just move, exhale, come on, breathe in, exhale, breathe in, exhale. And those are the diaphragmatic contractions that you're having. So this is what we want, because not only the core is determined by the transverse abdominis and all the muscles associated to it, but also with the power of the diaphragm behind it that is helping with the pressure. And we want the biomechanics to be restored such way. This is why, for example, in order to help my participants and some professional athletes to perform better, because when you're running, for example, and you're performing, your diaphragm is getting tired, it's not moving anymore, it's going to suck some blood from the thighs, at least 7 to 8%, and bring it to the diaphragm in order to sustain the movement. This is what we don't want. We want, because the legs can be jelly and we are losing focus, lucidity, pain, we're tired. So what we want is to train the diaphragm in order to avoid such kind of dynamic into the thighs and continue to perform if we're talking about sport performance. But from a clinical health domain, we want the diaphragm to be more online and harmoniously associated with the abdominal muscles. I don't know if it makes sense then.
It does. And how many repetitions of that would you do?
5.
5 repetitions of that.
Yes, 5. Breathe in normally, breathe out normally. Why do I like it? I like it also because it enhances your lucidity. While doing this, for example, in your case, you are more aware of different things, of what was occurring inside yourself. Maybe the sounds for some people are more intense. The colors are more flashy when they're doing this several times. After the get out of your head exercise, get out of your mind, they corrected me in Ireland to don't say, no, we don't say get out of your mind, get out of your head. So I'm adapting, guys. So to do this exercise in the end is very nice also. It is something that you can do it.
Alessandro, I know it's late in Italy, and I can't thank you enough for joining me. So I so much appreciate it. Thank you for giving us this knowledge. I think it's going to help a lot of people.
This is a drill for diaphragm awareness. A lot of times people, when we talk about breathing, they don't know where their diaphragm is. If this is you, you can try this drill before you try the breathing exercises that we have in this particular program. So what I want you to do, Christy, is I want you to put one hand on your belly, and I want you to put one hand on your chest. Now, I want you to breathe into your belly, so the hand on your belly should raise up to the ceiling. Now I want you to hold your breath, and I want you to push that air up to your hand on your chest. So belly comes down, and your chest should expand. Now push it back down to your belly, and now breathe out. Good. So again, breathe into this hand. Belly gets full. Push that air up to your chest. Yes. Push it back down to your belly, and now breathe out. Okay? So you're not going to breathe out until I tell you to breathe out, okay? So let's go again. Breathe into your hand. Hold your breath. Push that air up to your chest. There you go. Push it back down to your belly. And now breathe out. Okay? Again, breathe into your belly. Hold your breath. Push it up to your chest. Push it back down to your belly. And now breathe out. Good. Now, we can switch this, Christy. Breathe into your chest. Hold your breath. Push it down to your belly. Push it back up to your chest. And now breathe out. And at home in the camera, you should see when she breathes into her chest, breathe in. This hand moves. She's going to push it down to her belly. This hand moves. She's going to push it back up to her chest. This hand moves. And now breathe out. So what you can do is you can play with different sequences to figure out where your diaphragm is. But I always like to finish with the way it's supposed to happen. Breathe into your belly. Hold your breath. Push it up to your chest. Yes. Push it back down to your belly. And now breathe out. So that is just a quick little drill that you can do so you can gain awareness of where your diaphragm actually is, and that's called diaphragm awareness. Now, I just got done talking about the importance of breathing diaphragmatically, but sometimes that's easier said than done. So during my career, I have had to come up with a technology that would help people do a reset of their breathing pattern. And what I use the principles of infant development to create that reset. Now, what I mean by that is an infant, when it's born, is a ground-dwelling creature, okay? The infant's either going to spend time on its back or it's going to spend time on its belly. From there, from being on the belly, an infant's going to want to look around. So they're going to push themselves up, they're going to lift their head, and by the way, they're forming their curves and their tonic and their phasic muscles. And from there, the infant's eventually going to go from a ground-based creature to someone that's on their hands and knees. From hands and knees, now starts the crawling principles, and eventually an infant's going to crawl over to a coffee table or a couch, and it's going to pull itself up, and now it's going to be in tall kneeling. From tall kneeling, we're going to go into half kneeling, and from half kneeling, the infant's eventually going to pull themselves up onto their hands and knees and become the only creature on the face of this earth that walks with a vertical spine. So what does all that mean for breathing? Well, what I have found, if you are having a hard time breathing diaphragmatically, when your spine is perpendicular to the earth, if we take you back through infant development sequences, it's much easier. So for example, the easiest way to teach somebody how to breathe diaphragmatically is on their back. So if I put a client on their back, I can always put one hand on the belly and one hand on the chest, and I can tell my client to breathe into the belly. So they breathe into the belly and they breathe out and it falls. Now sometimes that's not even good enough. Sometimes you actually have to take a weight of some sort to put it on the belly to actually breathe in, so the person knows where the diaphragm actually is, and breathe out. Again, breathe in and breathe out. So what I'll do is I'll do reps of 10. Now that we're talking about breathing diaphragmatically, we also want to think about the sequence. The first 2/3 of the breath should come from the diaphragm. So the belly should come up first, and then the last third should come from the thoracic cage or the chest. Also, if you think about the thoracic cage as an umbrella, when you open an umbrella, it opens in 360 degrees. So not only do I want to feel like my belly is coming to the ceiling, I also want to feel like my thoracic or my rib cage is expanding out laterally, and I also want to feel like I'm actually breathing with my posterior ribs into the floor. So my tummy and my thoracic cage is expanding in 360 degrees. That would be a normal breathing pattern. Again, the first 2/3 of the breath, and with the diaphragm, also with the rib cage expanding laterally and posteriorly, and then the last third coming from the chest. So once my client can breathe good on their back, I can then take them into the hands and knees position, and now I teach them to breathe in this position here. So now when I take a breath in, my belly should drop to the floor. And when I breathe out, my belly comes back up toward my spine. Once they conquer that position, I can then take my client into a seated position, because an infant would go from hands and knees to probably a seated position. And in the seated position, they can practice breathing diaphragmatically again. Again, the first 2 breaths, 2/3 of the breath into the belly, the last third into the chest. From that position there, an infant would crawl over and pull itself up into tall kneeling. So this would be the next position that we would train. Again, the first 2/3 of the breath into the belly, the last third into the chest. From there, we would go into a half kneeling position. Again, same sequence. And we can actually switch legs, do some breathing that way. And then we finally, the infant pulls themselves up into being a standing human being. And this is where we go ahead and we practice our breathing with a vertical spine. Again, the first 2/3 of the breath into the belly, the last third into the chest. And if you want to take it a step further, you can then add some sort of challenge, say like a balance, make them stand on one leg, and then they still have to breathe diaphragmatically, or you have them do more than one thing at a time. So this is the technology that I developed, which I've had amazing success with helping my clients get back to the normal breathing mechanics of breathing with the diaphragm. This section on a holistic approach to pelvic floor health is all about posture. Now, why am I talking about posture when you have pelvic floor pain? The reason why is because many of you are going to be suffering from pelvic floor pain of an insidious onset, meaning I don't know why I have this pain. If that's you, I promise you that your posture has a little of something to do with your problem. We live in this body 24/7. And if you have a postural fault, it's going to absolutely have an impact on your pelvic floor. A guy by the name of Vladimir Yanda came up with lower cross syndrome, which is a syndrome that looks like this with an anterior pelvic tilt. And he came up with a upper cross syndrome, which looks a little bit like this, where your chest drops down and your head goes forward. Many of us today suffer from lower cross syndrome and upper cross syndrome. And if we do not correct that particular posture, it's going to have an impact on the pelvic floor. How? For example, if I stand with a lower cross syndrome, my ab muscles are all stretched out, and my ab muscles are very important for the health of my pelvic floor. If I stand with upper cross syndrome, now everything has dropped down. The transverse colon, the ascending colon, the descending colon, my stomach contents, which is going to impact your uterus or your prostate or your ovaries. That's all going to have an impact due to posture. So I just want to briefly talk about posture awareness. Now, the easiest thing to do for posture awareness is to use a wall as a reference point. So if I come to the back of my room, if I put my heels up against the wall, if I put the back of my hands against the wall, now if I put the back of my head against the wall, I'm in what's called a gravity line. If I have a good gravity line, my ears over my shoulders over my hips over my knees over my ankle, gravity cannot mess with me. But most of us in today's world, we look like the Leaning Tower of Pisa. So if you want to check yourself on this, if you think if you're not the Leaning Tower of Pisa, I simply want you to do this. I want you to march up and down a few times. Just go ahead and go no mind. And then I want you to stop, and I want you to close your eyes. And then all I want you to do is I want you to pick your toes off the floor. And if you feel yourself go backwards, almost like you're going to fall over backwards, you have an anterior gravity line, and you definitely need to work on your posture. So again, as a reference, if you use a wall, you want to put the back of your heels against the wall, you want to put the back of your palms against the wall, and you want to put the back of your head against the wall. Now, when I say the back of my head, I mean the back of my head. I don't mean the top of my head. If you are one of those people that can't put the back of their head and you're like this, you need to put a little tall wedge behind your head, because your eyes and your jawbone need to be parallel with the horizon. Think of it this way. If I put my finger on my chin and one finger on my forehead, the finger on my chin should be slightly behind the finger on my forehead. It should not be the reverse. So again, you're going to go up against the wall, heels against the wall, back of the hands against the wall, back of the head against the wall. Now from here, you're going to pick up your toes and you're going to push the crown of your head to the ceiling. When you push the crown of your head to the ceiling, which is the very top of your head, your chin should automatically come in. And then I want you to take your eyes and I want you to look 10 feet down in front of you. From here, many of you are going to have a big space between your low back and the wall. From here, all I want you to do is gently try to flatten your low back into the wall. That's going to create a posterior pelvic tilt. So again, to reiterate, heels against the wall, back of the hands against the wall, back of the head against the wall, pick up your toes, push the crown of your head to the ceiling, and now gently try to flatten your low back into the wall. Now, here's your goal. It takes roughly 3 minutes of time under tension to change postural muscles. If you think you're going to do that for the first time for 3 minutes, it's going to be easy, you're going to have a rude awakening. So what I want you to do, as long as you do not rest for more than 60 seconds, you can accumulate time under tension. So the first time you do it, maybe do it for 1 minute, rest for 30 seconds, do another minute, rest for 30 seconds, do another minute. You got your 3 minutes of time under tension. Then maybe the next time you go for 1.5 minutes, rest for 45 seconds, go for 1.5 minutes, rest for 45 seconds. You got your 3 minutes of time under tension. And then the third time you do it, maybe you can do 1 3-minute blast. Now, we don't live against a wall. So what do I do when I'm not against a wall? Maybe I'm at a cocktail party. Maybe I'm standing at the grocery store. Maybe I'm standing talking to a friend. This is your body. You need to check in and you need to control every aspect of your body. So when I'm not against a wall, here's what I do. I'm gonna turn sideways. I check in with my feet. I say, hey, where are my feet? I pull my toes up. And if I notice that I swayed way back, then I'm thinking to myself, oh, I'm looking like that Leaning Tower of Pisa again. That's not good. So there should be no weight on your toes. The toes should be free. So if you pull your toes up off the floor, your weight should be between the ball of your foot and your heel. That's number one. Number two, you check in with your pelvis, which is the most important. All you're going to do is just gently pull your belt buckle up towards your chin. That is it. So now you're going from that lower cross syndrome to gently pulling your belt buckle up, and you're going to notice that your weight's going to come back to neutral. Step number three, where's my shoulders? All I want you to do is put a little bit of tension between your shoulder blades. I don't want you to do this. I just want you to put a little tension between your shoulder blades. And now, the last thing you do is, where's my head and neck? Just feel like you're pushing the crown of your head to the ceiling. Feel like you're that beautiful African woman with the long neck going down to the well with that big pot and putting it full of water and carrying it back to camp on your head. Push the crown of your head to the ceiling. So now, if I just let myself just go into a crappy posture, watch how I change it. Pick the toes up, tuck the tail, shoulder blades back a little bit, and push the crown of my head to the ceiling. Now, my ears over my shoulder, shoulders over my hip, hips over my knee, knees over my ankle. I'm in a gravity line, and I no longer look like the Leaning Tower of Pisa. So this is really important if you're suffering from pelvic floor pain of insidious onset, meaning I don't know why I have this pain. I want you to work on this posture and just to become aware of your posture, and this will definitely benefit you with your pelvic floor issues.